Good evening, everyone, and welcome to RFL. I'm Richard French. We kick off a pivotal week in the fight against the coronavirus with some sobering comments from our Surgeon General.
The next week is going to be our Pearl Harbor moment. It's going to be our 9/11 moment. It's going to be the hardest moment for many Americans in their entire lives.
So let us get to those numbers here, which are rising rapidly. We now have 350,000 confirmed cases in the United States, and more than 10,000 people have died nationwide. The number of cases, well, they've more than doubled since last Monday, and the death toll has tripled since the start of last week. Plus, we are seeing the emerging hotspots in cities like Detroit, D.C., Louisiana, the state of, as well as Pennsylvania and Colorado. New York, though, continues to be the hardest hit city and state. Nearly 5,000 New Yorkers have died from COVID-19, and more than 130,000 people have tested positive. Roughly half the cases and fatalities are in the 5 boroughs. Worldwide, we are approaching 1.5 million cases. More than 73,000 people have died. The United States continues to have the most people who have tested positive, but Italy and Spain each have at least 13,000 deaths apiece. France, it is also approaching 10,000. Now, back here stateside, Governor Cuomo in New York saying things, well, there are signs, I should say, in New York that they may be hitting a plateau as the amount of deaths is leveling off and the number of hospitalizations slowing down. But he is making sure to be cautious that it is way too early to tell, and hospitals are still dealing with an unmitigated crisis.
The system is running at Redline, has been for days. This is the most intense management function that we have ever undertaken. So it's not here, in this situation, it's not what they want, it's what they need.
Doctors in New York are echoing the governor's concerns.
Places are running out of ventilators. There's shortages of masks.
We are seeing scores of healthcare workers in my own department, get infected, and that's true everywhere.
I feel like we've been at war for 2 years, and we've just started with this epidemic.
Nurses also sharing their stories and just how difficult it is to get through a single day.
If patients cough, it's all in your hair. I'm not feet away from them. I am 2 inches from their face. So I have COVID in my hair, I have COVID on my face.
I seriously starting to think that this is really starting to take a toll on me. Between seeing people die and having to work 12, 13, 14-hour shifts.
I am in a lot of moral distress because I'm not able to help patients the way that I'm accustomed to. I'm simply just trying to mentally stay well enough to take care of them and keep them alive.
New York is, as we've reported nightly, not just where the problem is, but in many ways a preview of what other states and cities will soon see. You have a government watchdog interviewed officials at 300 hospitals nationwide. Its audit, it shows the problems at the hospitals are widespread throughout the country. The report says shortages of protective gear and other critical supplies, testing delays, they've hampered their efforts to fight the virus. Also, many hospitals saying that they are suffering from staffing issues as doctors and nurses get sick and the number of cases only continue to grow. Back in New York, the situation, though, it remains bleak. The morgues, they are filling up, and the city's medical examiner has dispatched 80 refrigerated trucks as many hospitals have no place to keep the bodies. Now, even though that may not be enough, the head of the city's council's health committee is saying that they could start temporarily burying the dead in trenches in parks. Governor Cuomo, he was asked about that today. He said he does not support the concept. Now, my first guest tonight, he has worked in a half a dozen different emergency rooms in the past week in New York City. He joins us now to describe what it's like on the front lines.
New York City is the epicenter of America's coronavirus outbreak.
I had about 3 deaths in the span of the first 6 hours.
Emergency room doctors are struggling with limited personal protective equipment, PPE.
I see about 30 to 40 patients a day in an 8 to 12-hour shift. And I am wearing the same gear the entire day.
As you can see from my face, these battle scars.
And every emergency room in New York City is going to go through the same outcome, which is near, if not complete, collapse of the healthcare system as we know it.
Let's now bring in Dr. Calvin Sun. Doctor, thank you so much, not just for the time, but also for what you're dealing with. And I can't think of somebody with a better perspective of what is going on in New York, as you've been over a 7-day period. You were in 6 different ERs. We're hearing, and a watchdog report is saying that there is a massive shortage, not limited to a hospital here or there. From your perspective, this is being described this week by our Surgeon General as, you know, a 9/11 type event, or moreover, even a Pearl Harbor moment. Talk about just how ready the hospitals are to deal with what this week promises to hold.
Well, human beings are notorious of not being able to predict the future as accurately as we want them to be. So I hope that we are overreacting and that we will eat our words. And then a week from now, everyone's going to look at us and say that we totally overreacted, that we have too many ventilators instead of too few, and that, you know, that it wasn't as bad as we thought. That's what I want, right? I'd rather have that than a scenario where we do actually run out of ventilators because we failed to prepare, and we're now rationing care in the United States of America in 2020, and people are dying to the point where they're dying in the waiting rooms or on the street. Last week, I've had people die in the waiting room that I had to rescue, and they died anyway. So that's where we were last week. We already hit the effect. Every day feels like the apex for us in the trenches. So whatever they're saying of this being the worst week ever, we signed up for this. We went into this knowing that every day could be the worst day ever, and we're still going to go in. But please, just hopefully it's not as bad, as dire as everyone's predicting it to be. And if it is, what choice do we have but to keep going back in and treating the patients that we, you know, signed up to treat?
Doctor, one of the things that I've heard a lot of experts tell me is that they were surprised. They have been surprised by the patients themselves. A lot younger and healthier than they were led to believe. This was obviously not just something that would go after people with pre-existing conditions or the seniors. You're seeing younger, healthier patients come through your doors than many of us maybe would have expected a couple months ago.
Absolutely. The patients are younger than any of us expected. They're not the older patient population that we had thought about or been informed by the patients that showed up at Wuhan's hospital in China. But at the same time, their demographics are different, right? They have fewer children than we do. So there's a correlation, causation. I don't know, but I am observing something that is different. COVID-19 is not your typical flu.
To that end, Doctor, we hear there are some impossible decisions that folks like yourself are being forced to make here, given the scarcity of the ventilators, the beds, the resources. Describe a little bit about DNR decisions. We had, for example, EMTs that were with us who basically said if they can't find a pulse in the field, they're not even bringing the patient in. But even the patients that come through your doors, talk about some of the decisions that you're being forced to make that would have been unthinkable a few months ago.
So before the pandemic, us emergentologists or emergency physicians in the ER, we were accustomed to making DNR, DNI decisions within seconds to minutes with family for a patient that was critically ill, whether the patient came from a nursing home or an end-stage cancer, or, you know, just the inability to breathe, and whether they want a natural death, which some families think is more dignified than doing everything, which we break the ribs, we try to resuscitate the heart, we try to get going, put tubes and lines, we make the patients experience horrifically uncomfortable just to the concept of keeping them alive, which is different for different families in terms of their definition, or what patients' wishes were before they became critically ill, or what they wanted to do at the end of life. We're very accustomed to that. That was nothing new for us as emergentologists. What we're uncomfortable with is the rationing of care in the United States of America in 2020. The idea that a patient may not get everything that they need to survive. Before, we were doing everything for everyone. Now we're doing the greatest good for the greatest number. I personally have had training and experience in rationing care outside the United States in countries that didn't even have a CAT scanner. It's one of the most difficult decisions I have to make. I wish I never have to make it again. And it was unconscionable to me to believe that I would actually be making it in New York City in 2020. That's for myself. I can't speak on behalf of the other physicians, most of whom have never had to make those decisions because they have been in the United States for all their lives and never have been put through that. Officially, it's up to the state. The state allocation guidelines that determines that every hospital should have a committee that takes that decision away from the doctor unilaterally, so they don't have to be left with that choice by themselves.
Doctor, in terms of supplies, both the mayor and the governor have given various accounts, but they've been talking about days left in terms of PPE. Talk to that end. How concerned are you? I mean, when we look at, for example, some of the Asian models that, you know, there's going to be ebbs and flows to this. This won't all go away even if we start to flatten out the curve. How much longer, when you look around these ERs, do you think you have of the supplies that you and your colleagues are going to need?
We were running out of supplies even before this pandemic. This was a problem before it was a huge problem. I think that the attitude that I've experienced is, let's not worry about it until we get there. And now we're here. And we're literally getting by day. We're trying to find innovative strategies to keep our N95s last as long as possible. N95s are designed to be thrown out and be disposable between each patient encounter. So every patient you see, you're supposed to switch out an N95. Obviously, that's practically difficult and also unsafe, because if COVID-19 is now aerosolizable and living in the air of the emergency room, it's going to be difficult to swap it out, breathe in the air, and swap a new one in. So that's not possible. Ideally, what we need is a P100 mask or a PAPR, a positive air purifying respirator, to handle the patient volume that have COVID-19. But, you know, I guess maybe it costs too much. Maybe our lives are not worth it. I'm not one to judge on that, but that is the standard of care at other hospitals internationally that have been able to contain this more effectively.
Well, Dr. Sun, I know these are trying days, and I certainly appreciate everything you and your colleagues have done to this point, and certainly we're going to need you to do continuing going forward. Thank you as always. Appreciate it.
Thank you.
Up next, the president supporting the firing of a Navy captain who was trying to protect his men and women from the coronavirus. But the president, you may remember, he pardoned a Navy SEAL accused of war crimes who was turned in by his own men. After the break, we'll discuss this with a congresswoman who's also a former Navy pilot and who served on the aircraft carrier that the commander was just fired from.